Hey, it's Dr. Centeno, and I've done a few blogs through the years and one or two videos on what I call the WNL concept, or what I call the we never looked concept. And so this is an extension of one of those. This is going to be a little bit more provider focused, but hopefully patients can get something out of it too. This is a patient with damage to the fascia at T1 that's clearly visible on his MRI, but the MRI was read out as normal. He saw multiple high-quality providers who never even looked at this, and certainly never went over this with the patient. So I was asked to see this guy this morning, went over all this with him, and one of the things that I noticed was that this issue that he was having at T1 may be the genesis of some of the upper cervical problems he was trying to consult me for. So there's an old joke in medicine. WNL should mean within normal limits. It's what we doctors put on reports. But oftentimes it means we never looked, meaning we just never looked at that test result or that image. Now, one of the biggest WNL problems in providers who are practicing orthobiologics, and even sophisticated providers, they never learn how to read the MRI images themselves. And that takes years and years of looking at these images, looking at what the radiologist wrote, looking at the physical exam, looking at your own ultrasound, correlating all of that, treating that person, trying to determine if you were able to get them better based on what you thought was wrong, and that whole feedback loop. So sometimes it takes decades to get good at looking at these images and trying to diagnose someone's problems when the radiologist didn't really do their job. So this is the case of a 27-year-old who began having issues after a football hit years ago. His problem at T1 got worse with squats due to the bar placing pressure on that area. And eventually he was diagnosed with a small chip fracture of the T1 spinous process, and that led to surgical debridement of the area. And then after that, his problems got a lot worse. He's tried PRP injections and an MFAT procedure at that site with no results. And these were relatively high quality providers that he saw. And these MRIs that we're going to look at are 4 months after the last PRP procedure. So this is the useless MRI report for the images we'll look at. As you can see, everything's unremarkable. It looks like a formatted, computerized report. I didn't use Ashley's last name here. I blocked it out. The patient's name is blocked out. Ashley is darling down here. I even blocked her eyes out so you can't tell who she is. And she looks like a very nice person, but clearly she completely missed the boat here and what's wrong with this person. Now, I can't blame Ashley, the radiologist, because that's kind of the system we have, right? If she doesn't read a couple dozen MRIs during the day, then she's not doing what she's supposed to do. She's probably an employed physician. And that's the problem with the system, is she's not really being taught to look for these small things. She's being taught to look for the big things that can be determined quickly. If not, press the button for a normal report. So I looked at these images, and the first thing I was doing was looking at the image on the left, the sagittal down there at the spinous processes, trying to see if I could see any abnormalities. Then I looked at the image on the right, which is the axial from the level that was operated, or close to that area. And I started to notice something. Now, if you just looked at that axial on the right, you might not really notice much because we're normally looking anterior around the spinal cord, around the disc, the nerve roots. We're really not looking posterior. But if you really look closely, this is what you see. The green arrows here are the deep cervical fascia. So that's the dark line that I'm pointing to with those green arrows. And you can see it's nice and thin and dense. So in the body, normal fascial tissues, normal ligaments, normal tendons are tight and dense. But if you look on the right, where I've got the red arrows, that's outlining the parts of the fascia that have hypertrophied, meaning they're dramatically enlarged. They're about, in some areas, 5 times as thick. And that's generally what happens. Hypertrophy in ligaments, tendons, or fascia equals a weak structure. So we're seeing a weakened structure here. And that's kind of consistent where the patient has a genesis of the problems. He's saying it feels like he's got no anchor in this area, and then his neck gets all freaked out when he tries to do anything with his upper body. Now, what is the fascia and what does it do? It surrounds the muscles and it compresses those muscles to improve their efficiency. It also acts as anchor points between the muscles and other structures like bones that integrate the entire kinetic chain. Now, if you're a musculoskeletal provider and you haven't read anatomy trains, you gotta read this book. It'll blow your mind because it's all the stuff that no one ever taught you in medical school or residency or a fellowship program, other than if you're in our fellowship program. And it's about how there are fascial connections all over the body. So it's a great book to read. But one of the things that you notice in anatomy trains is what's labeled here as the SBL in the posterior cervical spine. So basically we've got fascial connections that anchor there at T1 and they go all the way up to the skull and all the way up the cervical spine. So this patient in particular has developed problems at C2, 3, 3, 4, and 4, 5. He's got, at 27 years old, he's got spondylolisthesis at all of those levels. So C2 goes forward on C3 inflection, 3 on 4, 4 on 5. That would make sense, right? The fascial anchor for all of those things that might help reduce that anterolisthesis has been disrupted by this surgery. And in fact, that's why I saw him, because he had upper cervical symptoms and he was sent to me to try to sort those out. Now there's another problem here. You can see on the left there, the semispinalis muscle at the green arrow is firmly attached to the supraspinous ligament. Supraspinous ligament is right in the middle there, labeled SSL. On the right, you don't see that. In fact, it looks like the supraspinous ligament is absent there. That's the white spot, or the top arrow, the red arrow on the right. The longer red arrow is pointing to where the semispinalis muscle attaches to that hypertrophied fascia. And you can see if that semispinalis muscle on the right contracts, it's got nothing to contract against. Whereas the one on the left with the green arrow does have something to contract against. So again, we're seeing this defect and this inability to generate force here, which is what he talks about, because these long neck muscles as well don't have attachment points here. So what's next for this guy? We're going to do high dose bone marrow concentrate delivered under ultrasound guidance and focused on the entire length of the hypertrophied fascia. He saw some good providers before, but my guess is they didn't do that. The entire supraspinous ligament, which is commonly injected in higher level clinics. But what's usually not injected are these fascial attachments between the semispinalis muscles and the supraspinous ligament. And then the entire length of the supraspinous and interspinous ligaments all the way up, including those fascial connections that I just showed you from anatomy trains there. And then we'll obviously be treating the facet hypertrophy he has specifically at C2-3. We'll probably upgrade him there from PRP to bone marrow concentrate in those joints. Now, if that fails, he may need surgical micro procedure, if you will, to repair the defect between the supraspinous ligament and the semispinalis. So that remains to be seen. But the moral of the story is you need to read your own MRIs. If you're doing orthobiologics and you're not reading your MRIs at this level, you should get there, right? You should be able to look at that MRI and say, oh God, what's going on here in the fascia? The left doesn't look like the right. I always tell patients that reading MRIs is often like a game of Sesame Street. Which one of these things is not like the other? If you remember that from Sesame Street way back. You've got a left and right that you can compare, and if you look hard enough, you can often see what's going on with the patient and explain what's happening, even when there's been a normal MRI report. So thanks so much for watching, and have a great day.